Right. I shall be just discussing two small cases which were of little bit of interest to me. So I'll carry on with the first one. So this is a 24-year-old medical graduate who came to me in June.
I think Dr. Vivek, I think a little bit louder. Yeah, little bit louder maybe.
Okay.
Chandra, just a second. Dr. Vivek, just a second.
Yeah. Is it audible better now?
Yeah.
Yeah, it is audible better. Give me a second, please. Dr. Vivek, please give me a second.
Yes.
Good evening, everybody. Welcome to this web series. I request Dr. Shivkumar Kalyanam from US and Dr. Anil Saxena from New Delhi to please start the session. Thank you. And kindly put your all your laptops and phones on mute. Thank you.
Good evening, everyone. This is Shivkumar from UCLA. It's such a pleasure to be a part of the IHRS session, and I'm looking forward to learning from everyone. On to you.
Yeah.
Vivek, please start. Thank you.
Yes. So good morning and good evening, everyone. I'll start with two short cases. The first is of a 24-year-old medical graduate who presented to me in 2019. He had self-referred himself for atrial fibrillation ablation. He didn't have any factors, did not have any addictions or alcohol intake. Has had paroxysmal aches 3 to 4 years, which was being managed by a local MP, that is Madhya Pradesh, with calcium channel blockers, digoxin, and then subsequently amiodarone. He has had no recent episodes of AF. And funny, every missed and syncope since 3 months, especially while resting. On examination, he had bradycardia, but otherwise the examination was unremarkable. Excuse me, the screen is frozen. I'll just come out and then go again. Okay. So these are old series of AF, but you can clearly see that there has been an AF young man years ago. And showed these ECGs for sun. So these were from quite horrible looking PVCs. When I looked at his mobility, I could make out that the repolarization was quite abnormal. Which on the day when I saw him, and again you can see that there is very pronounced wave. These two waves were activity was somewhere near 500, and then when I asked him in detail, he said his mother died of SD at the age of 32, and she had nebivolol and thyroxine because of amiodarone-induced hypothyroidism. His echocardiogram showed borderline ejection fraction of percent and some non-compaction of the left ventricle. So I advised him restoration of electrolytes and phenytoin. Now, phenytoin the phenytoin was started given that he had a dysfunctional heart. Amiodarone and flecainide were both out of question. Am I being audible clearly?
Dr. Vivek, your audio is breaking. I don't know if you can maybe switch off video, that may help your audio connection.
Okay.
So Vivek, are you on 4G or you are on Wi-Fi?
No, I'm on Wi-Fi.
Okay, still your audio is breaking, so I think it is a good idea to switch off your video for some time, and then your audio will be better.
Just give me a second. Is the audio better now?
Yes, it
Very
is
nice.
very nice.
Okay, great. So his amiodarone was stopped. He was started on phenytoin. His electrolytes came out to be normal, and his symptoms improved over the next week or so. His cardiac MRI showed global hypokinesia. The EF was reported as 33%, but was a bit doubtful about that because of the PVCs when the MRI was happening. There was no scarring or delayed enhancement or any structural abnormality in the MRI. A Holter repeated after a few days showed only few VPCs, and as he was anxious to go back, I discharged him on phenytoin, nebivolol, and thyroxine. Advised him to come back for follow-up with his affected uncle. He came back in August with his uncle with most of the palpitations being settled now. Uncle was an asymptomatic hypertensive but has had atypical for which he was advised a TMT. Based on TMT, he was advised angiography and antiplatelets with metoprolol. On going through mother's papers, it showed a diagnosis of DCM and an SCD at home. This was the ECG of the affected boy in 2019. As we can see that the QTC has reduced, the PR interval is a bit short, and the repolarization is still abnormal. This was the treadmill of the boy in August 2019. And here we can see that during stage 4, there is a bizarre kind of pattern seen here. It's difficult to make whether this is a part of T wave or is it a prolonged PR as per the tachycardia. But if we go towards recovery, then we can clearly see this notched kind of T wave and a separate P wave here. So the QTC did not shorten but did not prolong, it remained the same during the treadmill for this boy. Now coming to uncle, his uncle showed me the TMT which he had undergone 2 years back, which was showing these PVCs. So I subjected him to another TMT. This was ECG at baseline. And this was the TMT 4, which was 8. And then during recovery, he got this type of pattern of PVCs and bursts of NSVT. So this quite ugly looking NSVTs continued like that for about 5 minutes, although he remained asymptomatic. So then I went back and took even further detailed history from the patient. And this was the family history of this patient. So this was the index case. The mother had died of SCD. And another uncle, the one which underwent TMT, had silent NSVTs, while the grandfather had died of DCM. And in this generation before, 3 more people had died of SCD or DCM. So then I got his genetic testing done, and the common panel for DCM was done for this boy, and it came out to be positive for RBM20 mutation in exon 9, which was like a mutation. He was advised and plan for Ablation if his AF becomes controlled and severely symptomatic. His uncle was also advised analysis, but he refused at that point. And echo repeated at the same point revealed the same findings with better QTC and ECG and no PVCs. During winter, he had repeated episodes of short bursts of AF, on phenytoin and nebivolol. These, he said, were more pronounced with sinus bradycardia and fatigue, and used to typically happen at rest, at night, and after eating. So thinking that this might be some kind of a vagal AF, I switched him to mexiletine with pronounced relief. He plans to get an ICD done for himself and for his uncle after the lockdown. So just few words about the RBM20 mutation, which is a mutation in chromosome 10 gene called RNA binding motif protein 20. Now this gene slightly targets one of the common genes which are involved in mutation, which is titin gene. Most of the mutations are in 11. As far as the behavior of people affected in lamin mutation for DCM, arrhythmic potential. So with NSVT, VT, and it has a short interval and can have bundle branch blocks, and it is more pronounced and occurs earlier in men who also go on to develop DCM with cardiomyopathy and heart failure. So a worldwide registry in 2017 was reported, which had 74 patients across the world, 44 index and 30 cascade. Amongst them, STD happened in 50% and AF happened in 20%. The arrhythmic risk was similar to the lamin cardiomyopathy mutation. Subsequently, another large study came from Denmark, where 15 families, about 80 patients who had positive mutation need not be symptomatic, but 80 patients who were were followed up, and this disease had about 66%. Almost exclusively the sick patients belonged to the male sex. About 30% were asymptomatic, but 30% developed AF, and 30% went on to develop STD also. So the authors, in fact, strongly advised that, like lamin, the young patients who are males and who have DCM and who have an RBM20 mutation should actually undergo prophylactic ICD implantation. So my question to the panelists and others are whether we should go ahead with AF ablation if not controlled with class 1B drugs. Should he be given a prophylactic ICD, although it doesn't fit into the HRS 2019 criteria for ICD placement in channelopathies? And whether the uncle should also be offered a prophylactic ICD if his genetic testing comes out to be positive. Thank you.
बोल रहा है कि you are supposed
Everybody please put their phones on mute. Lot of background noise going on. Kindly put your phones on mute, and only the person who has to ask questions, kindly unmute the phone. Otherwise, put your phones on mute. And Dr. Vivek, a request, you have to speak a little loudly. Your voice is not audible to everyone. So please speak a little more loudly.
Sure.
Dr. Saxena and Dr. Shivkumar, please.
Hi. There is a lot of back.
Your phones on mute. Chandra, can you do that for me, please? Dr. Chandra Mohan Thakur.
But then you'll have to mute all. So I have muted all. So anybody who wants to open line can unmute himself, please.
Vivek, this is Shivkumar. This is a very nice presentation and also a serious real-world problem when you see it. So for us to understand, you have a very young patient who's been very symptomatic, self-referred, and are you able to sort of make an assessment of how much, to answer your first question about AFib, Nothing has changed in the world of AFib in over 20 years. And still the indication for doing something is drug refractory symptoms is what should trigger management. And of course, it has no impact on mortality, and it's purely going to be done here that is symptom driven. The bigger question, of course, becomes, the risk of, what is the tachyarrhythmic potential and the use of a device, which I think is going to be a more interesting discussion since you actually have additional data on that front. Let me turn it over to Dr. Saxena, and then we'll discuss this a little further.
I agree with you, and I would like to know what is the age of the uncle. If he's very old, maybe his risk may not be very high, so maybe we can not advise him ICD, but the patient being younger, definitely we must consider. Anup, what are your thoughts about the case? Dr. Anup, can you unmute yourself?
Yeah, can you hear me?
Yeah.
Okay. No,
Yes,
it's very
thank you.
good case, and a lot of things to be considered. So I'm not sure about the first thing what Vivek is saying, AF ablation if not controlled by 1B. I'm not sure about the AF ablation. But as you mentioned, like being very young, probably I might consider a prophylactic ICD for sure.
Yeah. So, yes. So just to probably my voice was cracking. About 30% of these young kids they die of SCD with this mutation. So and this behaves a lot like lamin mutation. So that's what my question was, because the authors of the last article which I referred to, they made a strong case for putting ICD in these people, although it probably still is not there in the HRS guidelines. The uncle is, by the way, 45 years old, so I think he's still
Okay.
young to still have the SCD risk.
Yes.
May I make a comment? May I make a comment?
Go ahead. Yeah, please, go ahead.
Yeah, my concern is that he has a very strong family history of cardiac arrest in the family. Mother died at a young age, and already mother's side, there were another 3 deaths which were there in the family. Considering that this fellow already has a mutation and has developed some amount of cardiomyopathy, and with a strong family history of cardiac arrest, would it be safe to let him go without an ICD? So that is my concern. So I would rather err on putting an ICD in this patient because of his family history being so strong.
Consensus is emerging that most people feel that ICD should be implanted in the index patient at least.
And the other option is
Dr.
what is the
Ullas?
role of beta blockers? Any particular beta blocker which helps in this condition? Like how you have it in long QT. So like that, any particular beta blocker has any role?
Yes. I hope I am audible. I'm not sure.
Yes.
Am I audible? Yeah.
Yes.
So, it seems to me that there shouldn't be any more discussion with respect to the ICD recommendation for this young boy. Maybe we should also look into that gentleman who has remained asymptomatic, whatever his age, he's probably not very old.
Ullas, you're not
80 plus
audible.
or so.
You're not audible, Ullas.
Yeah. Not audible.
Yeah.
Dr. Vilas, your audio is breaking. Probably you can switch off your video, then your audio will be better.
Sure. You know what? I'm going to be switching off. Not sure whether I am audible now.
Perfect. It is perfect now.
Yeah. So, let me just quickly begin with what I said before. I think there probably is no much discussion regarding the ICD recommendation for this boy. I think we should be strongly advocating an ICD for the uncle who probably is not older than, say, 85, 90 years. But he also had shown on his TMT those bigeminal PVCs and NSVTs, and with this kind of a strong family history, I think he also is a candidate for an ICD. See, I have another question, and that is something to do with this genetic mutation. Whatever the literature Vivek showed, there was no mention about the QT in that particular cohort, from one from Denmark, and I'm not sure another one was from where, but there was no QT prolongation that was noted in those cohorts. So maybe here we are dealing with one channelopathy as well as one cardiomyopathy. So I think the prognosis here is much graver, if you ask me. And we may have to be discussing something to do with his ECG. One which looked like, it is not, it is a computer analyzed rhythm. Probably that should not be taken into account. But soon after that, he showed another ECG. That was quite interesting. We may have to look into whether there are multiple genetic mutations in this boy, or this QT prolongation was also there in that cohort. These are my concerns.
So, Dr. Ulhas, thanks a lot for your very useful comments. The boy did not have any other mutation except this one. And as you correctly said, the long QT has not been said to be a part of this mutation per se. Although, as I said, and I've shown that there are very few diagnosed cases worldwide. So that is why probably everything known about this case is still not really out. The initial very prolonged QT was probably because of amiodarone, but later now I think it came down.
All right. So, you see, when we talk about the genetic panel in the suspected case of a long QT syndrome, we look for only few of the genes, not necessarily the hundreds of the genes which have been, quoted. So, absence of a particular genetic defect in that panel testing does not rule out an additional channelopathy. Essentially, I feel that this is really a serious genetic disorder, and there are multiple mutations. So I think we are doing a serious case. And one more thing, first, this qualifies for not waiting for the lockdown period. If you look at the recommendations, this is the case where we should not be waiting for the lockdown.
Yeah. So I've already advised him ICD as of 6 months ago. But one can only advise. One cannot really enforce it. So the person is in NCD.
I agree.
To come down. So if I have time, I'll just.
So I'm done with some info.
If I have time, I'll just share the next case very briefly about a very interesting atypical flutter.
Vivek, you have to talk loudly. People are not able to hear you. Please talk loudly.
Okay.
May I make a quick comment? This is
please.
Venkat Tulakanahalli. So I think it's a beautiful case. I think wonderful presentation as well. The couple of issues I thought may be helpful. One thing is, in a mutation like this, the denominator obviously is small to really come up with any sort of a conclusion for the guidelines to say this is the actual, strength of making a decision about ICD. I think this is case by case, and I think what you did appropriately with respect to the index case and also the family is appropriate in my mind. That's actually very good. As far as the atrial fibrillation ablation, as Shiv was pointing out, I think the more we know about atrial fibrillation, I think more you get a little bit nervous about doing an atrial fibrillation ablation for a patient, especially of this age, mainly because of the fact of proarrhythmia due to atrial fibrillation ablation itself. In fact, I was leaning towards in a different way. If it recurs, it becomes a problem. I was even interested to see what Shiv has got thoughts with respect to neuromodulation in a patient like this, because I think the more we understand, especially if it is a vagally mediated atrial fibrillation, if there is a lot to do with the way that the patient is presenting, is there any role of a neuromodulation at some point? I mean, this is not at this moment, where, when it becomes uncontrollable symptomatic atrial fibrillation. That may be something we need to think about in a situation like this. So I would like to hear Shiv's comments on that particular aspect.
Venkat, that's a great point, and I fully concur with the points that have been made. You can't let a guideline control the management for this patient, and the single most important thing is to make sure that he's a young, almost a child, has an ICD, because it's going to be a bridge. You don't want to lose this patient suddenly. But I do think there's going to be a lot more to be learned in terms of managing the arrhythmia. There is, of course, this feeling that some of these cardiomyopathies actually have a component of atrial myopathy. And we're also learning that the interaction between the nervous system and the heart is probably the underlying driver for fibrillation itself. So in other words, fibrillation could be a marker of both neural control and the myopathy itself. So I think the management that's been proposed and the plan that they have is exactly what almost any program in the world would do. And also the final question about the uncle being 45 also puts that person in a sort of an age bracket where you wouldn't want to take a 3 out of 10 chance that that person could die suddenly. So
correct.
Neeraj Verma here. Both.
Good morning. Just
yeah,
to comment,
hi,
I joined. Hi, good morning. I joined the case late. I found that I caught the last half. I see your last slide about ICD prophylaxis. It doesn't fit DHRS 2019 criteria. A couple of points. The 2017 criteria from the ACC and AHA actually do support an ICD as a class 2A indication for lamin AC. And I believe you have a lamin AC kind of genetic variant here. So you do have guidelines that would support an ICD implant here. HRS and EHRA will probably come out with another set of guidelines regarding genetics and cardiomyopathies and arrhythmia risk in the next 2 years, so something to anticipate there. But in any case, your ICD here as a prophylactic measure is supported by 2017 ACC guidelines.
Great. So, Vivek, can we move on to the next case by Avinash and then get back to you once we have time left?
Yeah.
Okay.
Yeah, so I'll just rush through the next case because I know the time is has been progressing. So I'll just rush through this case. So this is a 60-year-old female post PCI 2010 for multivessel disease, has had recurrent palpitations with pre-syncope, a normal ejection fraction, a little bit large LA with moderate MR, and patent stents. For the palpitations, she had been on amiodarone and beta blockers. This was the baseline ECG, which was pretty much unremarkable. And then this was a tachycardia ECG, which showed a narrow QRS supraventricular tachycardia, cycle length of 420 milliseconds. So I took him to the EP lab, and the morphology kept on changing. Sometimes it would appear as if it's a perimitral AT. The right side was quickly ruled out, by the way, right in the beginning. Then it appeared both clockwise and counterclockwise, also tachycardia, flutter with flat CS activation, and differing cycle lengths from about 280 to 370 milliseconds. So after the transeptal puncture, imagine my surprise when I couldn't find any voltages anywhere in the left atrium. And so this was, just some, the ECG morphology of the flutter and the CS activation pattern. And then suddenly the tachycardia cycle length would keep on changing. And the morphology would also sometimes change from flat CS activation to proximal to distal CS activation. So meanwhile, the patient became restless and we suspected a perf on fluoro. So the case was abandoned and the echo did not show any pericardial effusion. But after taking the patient out of the lab, she became quite symptomatic with incessant flutter with rapid ventricular rate, requiring high dosages of amio infusion. So took her to the lab again after 4 days of amiodarone, and this was the ECG before. Now just you can see that the ECG has changed from the last one. This one has much more pronounced inferiorly directed forces. Then again, this was a fast tachycardia here with a flat CS activation. And then again, it just kept on changing. The cycle length kept on changing. Any attempts at entrainment would either accelerate the tachycardia or even decelerate it. So here you can see that a faster tachycardia after entrainment has actually become slower. And then it was the activation pattern was going all over the place. So I could not make out what is the origin for this kind of a flutter. So after the transseptal puncture, I was in for a big root shock. You can see these two modified AP and PA views, and these are all taken by a MAP catheter. And although it wasn't a contact force catheter, there were cost constraints, but I did try to make as good a map as possible. And almost the whole of left atrium was fully scarred. As you can see, my thresholds were 0.5 and 0.1, and except for little bit of the roof and little bit of anterolateral LA, everything else was just a scar. Again, this PA and superior view shows almost bald the posterior wall, as well as little bit, hardly any voltages except anteriorly on the roof. So on that anterolateral part extending from mitral annulus to the LIPV, the ablation signals were very interesting. As you can see in the ablation signals, there was huge, very prolonged activation pattern suggestive of CAFEs, and this was almost continuous. Meanwhile, the macro reentrant tachycardia was kind of becoming degenerated into an AF at the same time. And you can see that the pattern for AF has already started appearing on some of the CS catheters. And there is almost continuous activation of the MAP catheter on the anterolateral left atrial. The tachycardia, so I started burning in that area, and the tachycardia terminated near the LIPV. So if you can see here, this was the only patch which was having some low voltage areas, and the continuous signals were received right from here all the way up till here. And as I was burning from here to here, the tachycardia terminated. So the AF actually terminated, because by this time it had become, as you can see here, that it had become into an atrial fibrillation. The fluoroscopic image is here. And these were the activation pattern in the MAP catheter when this happened. This is a zoomed out view of the same, and you can see that this area has significant low voltage areas, except for a small island of so-called normal tissue, although probably this was also less than 1 millivolts. After this, on reinduction with extras, another tachycardia which was slower started, about 420 milliseconds, and this terminated on the roof on the remaining area which was low voltage. So this area. So I made a roof line, posterior MI line, and after that, since then, it was rhythm and discussed on metal. Now, when I was trying to look up literature for this, most of the literature for LA flutter is mostly for people with either rheumatic heart disease or surgical procedure done. Whatever references I could find are mostly spontaneous scar-based, mostly in Asians, either East Asians or in India. I mean, I don't do many cases, but even so, in the last year and a half or so, I must have done about 8 cases of spontaneous scar-based LA flutter with almost normal left atria. The other question, obviously, which I wanted to put to the panel was, should a PVI be done in these people? None of the ECGs, clinical spontaneous tachycardia ECGs in the past had ever shown anything except an organized atrial flutter. So if you find this kind of a scenario, should you go in and also complete the job in terms of a PVI? Thank you.
Nice case, Vivek. Do you remember, was there any evidence of any rheumatic kind of valve disease or any history of rheumatic fever in this patient?
No. There was no history of any rheumatic heart disease at.
Because that is something that comes to mind as a first possibility, that some kind of carditis might have happened in the past, because there is obviously a lot of scarring in the left atrium. And as far as the question about PVI is concerned, I think it would be a good idea, because patient may have a recurrence. So, and there is extensive fibrosis in the atrium. So there is always a concern about recurrence of these arrhythmias from some other zone.
Yeah, I think I gave it a skip, because I think by the second time and 3-4 hours gone, I was tired, I guess. So I didn't go back and finish the PVI. But the veins were silent, actually. I didn't have the veins, and they were silent.
So this was in the inferior antrum. This was in the antral area that you burned on the RIPV side, LIPV side.
So this was more like a posterior MI line on the left side and a roof line.
Okay.
Yeah.
Okay.
And the cafe-based ablation for the flutter and the AF.
Dr. Shiv, your comments, please.
Okay, this is a wonderful case. I really enjoyed the presentation, and of course, what you point out is something classic that all of us have seen in our practices, and you can get macro reentrant atrial tachycardias even in the absence of previous surgery, and the etiology, of course, becomes it's nothing special about Asians. I think it's seen in almost every group, and numerous labs have reported this. In the absence of prior cardiac surgical interventions, atrial scars can still be formed due to multiple mechanisms. It's postulated that some of these may be, people who have had, pericardial inflammation, for instance, that could have sort of had a mild form of carditis that is here healed. And some of them are idiopathic, and perhaps some of these are also small atrial muscle arterioles that have been occluded because of disease. So it's not uncommon to see atrial scars leading to this type of a presentation. And your case is also another beautiful example where mapping, you're seeing also this spectrum between macro reentry and, of course, a nidus that's actually driving rest of the atrium in a fibrillatory conduction. And the most fascinating part of your case is, of course, the fact that some of the standard approaches that we use, such as entrainment and so forth, ended up being not so useful because of the fact that the tachycardia itself was either accelerating or slowing down. So congratulations on a very good outcome, and also for good thinking, during a case to finish it. If the veins were silent, there's no reason to persist and make a longer day in the lab in terms of doing a unnecessary PVI. And I'm also happy that you were not tempted to go make additional lines, because they tend to be pro-arrhythmic. So congratulations. This is a very well managed case. And I'll try to project one image while Dr. Saxena and others make a comment, as an image that the IHRS colleagues would enjoy in terms of how to interpret mapping studies.
Dr. Lucky Reddy wants to make a comment about the possibility of association of this kind of scarring with rheumatic or some other myocarditis. DJ, hi, good morning to you. You can unmute yourself.
Hey, how are you?
Yeah, fine, thanks. Yeah.
Excellent case.
Make a
I think
comment.
Yeah. All the points that Shiv made right on the money, and oftentimes we see this in patients with non-ischemic cardiomyopathy, myocarditis, Chagas disease, right? I mean, anytime you have a non-valvular scenario, and even cases I think where somebody had rheumatic heart disease with limited endocarditis with no significant valve involvement can also lead to this type of picture. So great case.
Wonderful.
Yeah. So the only remaining question I had was when I tried to look in the literature, the only references I got were from East Asia. I mean, I tried all kind of combination, but almost all left atrial flutter cases from the West, specifically from US, seem to be only after MACE or after any ablation.
There are other reports, Vivek, and I think this is where I wouldn't sort of over-rely on the published literature because there's a lot of reporting bias. But this is probably the commonest cause of scar, which is left atrial in origin, perhaps because of stretch and so forth. So I think here the literature is not a good guide compared to what he actually did clinically.
Venkat, would you like to make a comment?
There is a question by Dr. Anup on the chat. Yeah. Hello? Hello?
Yeah, one quick comment. I think this is Venkat again. The flutter along the mitral isthmus area. I mean, I have seen like a few cases where endocardially it terminates. You want to make sure this is not conducting epicardially through the vein of Marshall, and it may not be a bad idea. If it does recur, I think that is the location I would look for. I routinely try to do an angiogram of the coronary sinus to look for this vein of Marshall area. And often, and I have quite a few examples of anatomical specimens showing this ridge area can be as thick as 1 centimeter. So that means endocardially, you may not be able to ablate that area transmurally. So it can conduct quite a bit. That we need to keep in this mind why recurrence happens in this situation. And endocardially, it looked like a dead zone. The voltage may even look. Sometimes unipolar voltages may be helpful, but it is something I think to keep in mind. Thank you.
Thanks. So I think we can move on to the next presentation by Dr. Avinash Verma. He'll be presenting a case with high Walker short duration ablation of atrial fibrillation.
Sorry, one 5-second update.
Yeah, sure.
I just put together one snapshot which I think our colleagues would enjoy looking at, and that is this is going to repeatedly come up when you do post-congenital mapping, when you're doing regular AFibs. So in other words, interpreting mapping studies is not easy. And I just put up this quick slide as just a passing comment because...
Yeah, Avinash, can you unshare, and then Dr. Shiv wants to share his screen. Yeah, Dr. Shiv, you can share your screen now.
Are you able to see this?
Yes.
Yeah.
Oh, so this is just, literally 5 seconds. I wanted to just show this to the IHRS team, just so that our colleagues can look at sort of the interpretation of all the published literature when you look at the big picture. People have looked at both clinical mechanisms of arrhythmias and also experimental maps. So what you see is not always perfectly fitting into one sort of a group or the other, and many a times you have unstable circuits. And I think what you probably saw in this case is an example of something like you have one source that is driving the rest of the atrium, and you're able to actually get the the main driver of the arrhythmia, which could have been a micro reentrant circuit. And this also goes to show that sometimes in the clinical setting you can never ever exactly pin down a mechanism. So I think this is going to become more and more with multiple multi-electrode mapping and things that are coming up, we're going to learn a lot more about arrhythmia mechanisms. And also, as Venkat pointed out, the epicardium is becoming an important driver in some of these atrial arrhythmias. We often think that the atria are very thin-walled, but it's a very unevenly thick structure. And sometimes, you may actually have to map, through the coronary venous system, the vein of Marshall, and sometimes we also do percutaneous epicardial ablation to control atrial arrhythmias. I'll stop there in view of time.
Thank you, Dr. Shiv. So, Avinash.
Hey, good evening, everyone. I hope I am audible.
You are audible. Thank you.
Good evening, everyone. Thank you, Dr. Saxena sir, Dr. Vinita, and thanks a lot, Dr. Kalyan, for your wonderful comments. And congratulations, Dr. Vivek, for wonderful cases you presented. So today I'm going to present a case of high-power short-duration radiofrequency ablation. These are some cases which we did recently. And so till now, we have done around 10 cases in past few months. Most of them were paroxysmal AF, but some were long persistent atypical AF flutter and post-AF ablation AF, post-AF ablation flutters. Out of these two, what we were concerned about most was the safety. With high power short duration, what you can achieve is PVI, isthmus line, roof line, posterior line. Any atrial ablation can easily be done with that. So out of the 10 cases, we haven't had any major complication because we were not sure how to handle this high power short duration ablation. For initial few cases, we routinely do endoscopic testing to see the esophageal injury and all. So there was one case we found where a small healed fibrosed ulcer kind of a thing was there. It was not exactly ulceration, it was just a whitish patch, which the gastroenterologist labeled as a healed lesion. And this patient we did was without GA because he was having ankylosing spondylitis and his neck was completely rigid. So they cannot intubate. So this was high risk intubation. So we did without GA with conscious sedation. One case we have pericardial effusion, which was managed conservatively without even tapping. But apart from that, touch wood, no safety concerns as of now. There have been just one recurrence in case of long persistent AF. This patient presented with atypical flutter, and he did so during this lockdown period. So we are planning to get the ablation done once the lockdown is over. So this case is case number 8 of this series. The 76-year-old gentleman, hypertensive, normal LVEF, LA size is normal. He is the classical case of paroxysmal AF. He's having it for 2 years. He has tried multiple medicines, including amiodarone, and he has not responded on amiodarone. Because of his hypertension and his wall thickness of 1.2 centimeter, we are not giving him any flecairide. So we posted it for ablation. Now, when we started doing the case, as sometimes we find in these cases, you have very tough septum not being able to puncture through. Then finally, I used a cautery to puncture through the septum, and then successfully the septum could be punctured even without applying much force. Then double wiring. And then what we did in all these cases of high power short duration, all these cases were with Penta-Ray and with contact force catheters. Penta-Ray helps in making the procedure duration even shorter. So all 2000 points acquired in less than 15 minutes, sinus rhythm map with very good high density with a 20 resolution of FAM can be completed in very fast. But if the heart rate is slow, particularly these cases, once they are intubated and put in GA, then we do the mapping on 600 milliseconds. So next important thing which we do is then test the editing. This we have realized that in cases of HPSD, you don't have time or the leisure of forming a lesion. You have only 5 to 6 seconds. So you have to be very accurate with your anatomy. So if any ghost shell is there, then you can have more than required contact force. You might be thinking you are in contact, but you are not in contact. and secondly, your ridge demarcation will not be that appropriate. So we spend some time, maybe 5 minutes, in map editing, and drawing line is another part of map editing. So we make sure that we draw big Waka lines, because with HPSD, drawing lines is really fast. So this is our setup which we keep for HPSD ablation. So we keep two views, one semi-transparent view and one endoscopic view. As you can see, the most important thing is that VisiTag setup. So we make sure that our lesion is contiguous, and every 3 millimeter we give a lesion. So with respiratory adjustment on, stability range of around 3 millimeters, and stability over time range of 4 to 5 seconds. I'll discuss the importance particularly of these two values in HPSD in later slides. After that, the power is fixed at 45 watts. The only thing which we vary is time. So lesion duration in posterior wall and roof is around 6 to 10 seconds, and anterior wall and inferior, where the size is thick, particularly in the ridge area, it can go to 15 seconds or even 20 seconds. So this is how contiguous lesions are applied, and we make sure that the distance marker is on in the VisiTag, so we continuously know that we are not missing any point. So after the first pass, which lasts of around 20 minutes, 25 minutes, your RPV becomes silent. And then my technician says that RPV is silent and it is spontaneously firing. Although it looks connected to me, even though it looks as if it's disconnected and firing. But RPV is just a minute. Okay, so just wait for 1 minute, and after 1 minute, we waited for 1 minute, and within 1 minute, it was showing connected again. So as we can see, the RPV is connected, but it is connected with a tremendous delay. So definitely we have damaged the area, but there is some residual connection which is left. And this connection was very flimsy. You know, spontaneously it used to go away. So it was spontaneous entry block happening in the Waka line. So when we maneuvered the catheter around that area, so VisiTag is another way to see that which area can be cause of the leak. So most light areas, which are the areas which have received the least power, are the most likely area. So we went towards that area, and as we went towards that area, just by catheter pressure, these entry block, it suddenly stopped and vein becomes silent. So by using the replay module, we can go back and give some lesions, and after that we waited for 5 minutes and the RPV was silent. So then we started doing our left-sided ablation, left-sided vein ablation. Now, as you can see, there is one lesion given here where the green line and yellow line meets. Now, this is our temperature catheter. Now, what we have done, if you can see on the right side, we have tied the esophageal temperature probe to the electrode, and that electrode is then connected to the CARTO, so we can see the temperature probe, or somewhat like temperature probe, in our CARTO system as well. Now, as you can see, this temperature probe is slightly leftwards than the actual probe. So probably where my green line is, that is the area of the esophagus. And as you can see, our original design line, it covered this area. The yellow line was the original design line, and it was bang on the esophagus. So just by giving a 5-second lesion, the temperature from 37, it went up to 39.8 degrees centigrade. So immediately we knew that we have to change this line and go for somewhere else. So we made the line more medial and started ablating on the medial side. So as you can see in the lower bottom fluoro image, over here we are sufficiently away from the esophagus. So after that, the next problem which came was while we are ablating the ridge. So in this patient, he had a very thick ridge, like somebody was mentioning, the ridge was very thick. So whenever we make a Waka, we make sure that we don't give, or at least try not to give the lesions from the vein side. So we started tracing the outer margin of this ridge. As we were tracing the outer margin of the ridge, we realized that our catheter was swaying totally inside the appendage. So this area was going totally inside the appendage. So we had to abandon this. And as you can see in the next slide, went inside the line or the inside the vein, and as you can see the distance from that last lesion, which was on the other side of appendage to this side of appendage, is around 1 centimeter or 10 millimeters thick. This was what the doctor was making comment, that it can be very thick. Now, if this ridge has to be ablated, we ablated both on this side as well as try to stabilize the catheter over the actual ridge also. So if you can see on the right side, these are the ablation lesions that were given by VisiTag, and all the red dots, the dark red dots, these are all the lesions which are not the maroon dots, but the dark red dots are lesions which are more than 10 seconds. So these are the lesions which were given on the inside of the pulmonary vein, but it was for very short duration. I would say only let's say from 9 o'clock to 10 o'clock or 10:30. This was the only area, maybe 10% of the circumference, in which we came inside the vein. Otherwise, all the rest of the circle was outside the vein. So this we make sure that we don't do. And the PVs, they become silent after that. Left PV became silent. So after the left PV became silent, we went on the right side, and we find that the right side has again reconnected. So what we did then was did a fast activation map using the pentarray. And as you can see, the point of reconnection, the closest ablation point, which has been made bigger over here, the lesion was only 5 seconds. And it was 5 seconds because it was 45 watts and it was at the roof. And in the roof, even because we don't use jet ventilation, so even with mechanical respiration, the forces can vary with each inspiration and expiration. So sometimes the force will be 15 and another time it will be 5. So that's why the lesion was kept small, and this was the site of and cause of leak. So and it is a very discrete activation map. It takes very so I find it more conducive to do this rather than put a lasso and then try to map it. As you can see, in entire of the right PV, all the right PV is connected, and the earliest point is near the roof. So we gave 2 lesions there at the roof site, and as you can see, it was connected, and after giving the lesions, it became disconnected, and now we are having a true spontaneous firing. So this is the actual spontaneous firing. There is no reconnection, and as you can see, it doesn't go out. We also checked for, so RPV is silent then. We tried reinduction with 20 mics of isoprel after waiting for 20 minutes. It didn't happen. We tried adenosine test. It didn't show any reconnection. After that, we did remapping. In remapping, it just takes 5 minutes to make a substrate map, and with the pentarray. As you can see on the lateral margin, you're getting a lot of red areas. That was not because of any isthmus sign that we created. It is because we were mapping in CS pacing, and the pacing, the mapping algorithm or the window was excluding the pacing spike. So we made the mapping window smaller so that it can take the depolation just after the pacing spike. And as you can see in the later thing, the red thing goes away. So after that, so this is our post and pre and post map. So this is the pre map, the RPV is connected, and this is the post map. This is again pre and post. This is the RPV in the right lateral view showing pre and post. This is the RPV in PA view showing pre and post. Similarly, on the PA view, you can also see this is the aborted lesion on the yellow dot, and these are the lesions on the left side. Similarly, the LPV, which was looking like a small vein, but it was actually going inside and then bifurcating. It had a big antrum. If you see from here to here, the sleeve is quite long. So whole sleeve was then disconnected. Here I have marked the ridge, how thick the ridge is. So this is the LA appendage on the left side, the pink area, and the red is superior PV. And you can see it's 1 centimeter thick ridge that is there. So one way to get around it is to ablate on both the sides, and then you give some dots in the center also. So after that, the procedure was complete. So this is what in few cases that we have done, we have found out that these parameters, if these things we keep, these help in streamlining our workflow and making it fast and more effective and safe. So respiratory adjustment we always keep it on because it makes our lesion stable. Another thing is when you keep respiratory adjustment on, it adds 1.5 to 2 seconds to lesion formation. So for example, you have set a stability over time of 5 seconds and respiratory adjustment is on, then you will see the lesion after 7 seconds. So that is something important because with HPSD sometimes you just need a 5-second lesion or 6-second lesion. So in that case you have to keep stability over time shorter. So what we keep as low as possible. So 4 is stability over time which we keep. Stability range on the other hand we keep it 3 because if you keep 2 stability range you will have a scatter of lesion. In the same ablation session you will have more than 1 lesion even though you are not having too much motion. So we keep anywhere between 3. Another thing is interlesion distance because HPSD lesions tend to be wider. So we keep an interlesion distance of at least 3 millimeter so that we are not overlapping these lesions. So overlapping of lesions should be absolutely avoided in case of HPSD. Power is 45 watts fixed. Lesion duration is also fixed. So importance of VisiTAC parameters in HPSD. Now, if you can see this stability over time 3 millimeters and stability over time 5 millimeters. Here you can see the number of lesions is higher, but you are seeing a very discrete, nice line. On the other hand, on the right side, if you see, you are seeing a plethora of lesions which are actually they should not be there because the stability range is kept at only 2 millimeters. So if you keep 2 millimeters, you will feel that there are a lot of overlapping lesions, but actually they are not. So if the lesion size is around 3 millimeters to 4 millimeters, we keep the stability range also of around 3 millimeters. Now, this is the importance of VisiTAC parameter. This is in the same case. If you see, this is the lesion of our near the esophagus. Within 4.75 or 5 seconds, we see that the esophagus temperature reaches 39. So suppose if you have in 4 seconds you can see this, but if you keep the stability over time, like in conventional, if you are doing conventional ablation using 20 watt and 30 watt, you want at least 10-second lesion. So you will keep it 6, 8 or even higher. So over there you will see that you will miss it. There is no lesion here. So lesion will not even appear there and you will be damaging the esophagus. So always keep the stability over time in case of HPSD to around 4 seconds and not higher than 5 seconds in any case. So more than 6 and 8 is absolutely no. As you can see, a lot of lesion in the posterior wall will go away if you keep stability over time at 8 seconds. So this is our RF data for this case. So total lesions, so if this data is available for the entire case, so total lesions given were just 100 lesions. Average total duration was 18 minutes. So this is total RF duration and it correlates with the duration that has been given by Dr. Natale's group and other groups. So overall, very less amount of ablation is required as compared to if you take the normal power ablation or 20 watts and 30 watts conventional ablation, it will be more than twice the amount of ablation that will be required. The average duration of the lesion was only 10.9 seconds. So it can make it very fast. And then average force is only 10.9 grams, average temperature only 37.7 grams, and impedance fall is around 15 grams. As you can see, this is the first lesion that we give. It just melts away. Within 5 seconds and 6 seconds, you see at least 10 to 15 ohms drop in impedance. So impedance drop and EGM going away is not at all a worry or consideration in this because it just goes away. What we are concerned more about is please do not exceed the lesion or the time limit. So that time limit is bound. So this is our data of the posterior wall in this case. So as you can see in the posterior wall, majority of the lesion. So this is the lesion in ascending order of duration. Okay. So in the left hand side you are seeing a time in seconds. On the right hand side you are seeing the number of the lesion. So there are total 35 lesions on the posterior wall and roof which were given, and they have been arranged in the ascending order of duration. So as you can see, if we see the cutoff of around 10, more than 70 to 80% of all the lesions given on the posterior wall and roof fall into this category. So they are less than this duration. So that is important. So if you see our overall duration, posterior wall and roof ablation requires 5 minutes. Average duration is 8.5 seconds. Average force is 10.4 gram, and impedance drop is around 16. If we see similarly on the anterior wall, inferior and lateral wall, including the ridge, so the lesions are around 65 lesions arranged in ascending order according to the duration in time. So as you can see, only around 10 lesions were given for less than 10 seconds, as compared to 70 to 80% of lesions for less than 10 seconds in posterior wall and roof. In the anterior and inferior wall, only 10% of the lesions were given for less than 10 seconds, and all other lesions were given for more than. So average duration was around 12.2 seconds. So duration is the most important thing to take care about while doing HPSD ablation. As of now, we don't have ablation index, because ablation index would have automatically calculated all this and would have given you a value to follow up. So this case already 2 months follow-up, he's asymptomatic till now. So the conclusion is that HPSD is safe and effective in atrial fibrillation ablation. Considerable shortening of RF time is observed. Procedure time is also shown considerably. Total procedure time in this case was 3 hours. This is right from puncture to the end of ablation, waiting for half an hour, reinduction with isopropyl and adenosine. So everything included in 3 hours. Esophageal temperature monitoring is essential, particularly when you're dealing with high power short duration. There is a thinking that high power will not damage the esophagus. Till now, it's not proven. It is a hypothesis that because of less duration, the conductive damage will be less. But as we saw in this case also, and as we see in all the published series, they have 99.9% or 99.7% of cases they were doing with esophageal monitoring. So it's safer to do esophageal monitoring. Different workflow is needed with different ablation parameters for HPSD. Like I mentioned, the stability over time has to be kept short. The stability over distance have to be kept around 3 millimeters. And the most important thing to worry about is the lesion duration, because rest of the things, and obviously the force. The force has to be between 10 gram, 9 to 10 grams. So if you see, the average force in the anterior and inferior wall was 12 grams. And if you see, the average force in the posterior wall and roof is 10 grams. So even if we are doing posterior wall and roof, it doesn't mean that our force can be less. It just means that our duration has to be small. So that is the one thing that we need to vary, the duration, and try to maintain the same force. It will give a consistent result. So importance of sticking to time limits is to be stressed there. So thank you all for patience listening.
Avinash, I think that was a great presentation and great work. You're so impressive. Any comments from the panelists? Dr. Anup, you want to comment? Dr. Shiv?
Very nice presentation, very beautifully done. There is a Heart Rhythm Society late-breaking clinical trial which is going to be simultaneously published on this subject on May 5th. So I think the group can be tuned in to see that. So this is a very nice presentation.
Thank you, sir. So what I wanted the comments about is that using HPSD, like I have shown HPSD being used for all atrial arrhythmias. So particularly using in other kinds of atrial, like I didn't show, but I've done a few SVC isolations also in the same case with HPSD, and as well as using high power short duration for other atrial arrhythmias. Particularly, I'm talking about flutters. I'm not talking about focal arrhythmias. So if there is any experience of the panelists and moderators on this.
Dr. Shiv, do you have any comment on that?
Look, yeah, and I think we can have other colleagues and Dhananjay and Venkat comment. This has been around.
Dhananjay has left actually. Venkat is there. Yes. Dr. Neeraj Verma is there.
Perfect.
Neeraj, you want to comment?
Yeah, no, it'll be great to have Neeraj and others comment. And of course, this has been around for over a decade. A whole lot of studies have looked at this, and clearly there is a lot to be said for high power short duration. And of course, you have to be super careful about all the concerns that we have with AFib ablation, especially damage to pericardiac structures, esophageal protection. So none of those risks go away with this or any, ablation strategy we use. So, I'll probably hand it over to others who can make a quick comment about the fact that this is now getting to be more established, and there's going to be a late-breaking clinical trial SHRS about this.
Dr. Neeraj Verma, you have any comment to make about this? Dr. Neeraj has left probably. Ajay Nayak.
Can I ask a question to Avinash?
Yes, please. Oh, Dr. Ulas, please.
Hey, Avinash, great presentation. Avinash, you have been the proponent of this HPSD. If I remember correctly, for the last 1 year, you have been advocating this technique. Let me ask you, why are
October 6 months?
For us, what is important is to go for the safety, and there are methods by using the so-called conventional ablation, and there is so much of a wisdom that is gathered. Why are you attempting this so-called relatively near technology for the Indian EP guys at least? What is that drive you towards this high power, short duration?
Sir, if we see various publications which have come recently, particularly there have been series published of more than 13,000 cases, it shows an excellent safety record. Plus, it shortens your procedure time also, and plus very less amount of RF energy is required. So the quantum of RF ablation that you are doing is less, and the endpoints are very precise. So all these things, it made me go for it because it's more objective, like I see it.
See, Avinash, when we are talking about the short duration, at many of your lesion points, the duration almost touched 20 plus.
Yes, that's for the
short duration. That's not short duration.
That is for, sir, in case if it touches 20, so something happen like Dr. Andrei, what he does is that you put your leg on the paddle, and if the catheter moves to another location, new lesion starts developing. But the ablation session will be the same. So the time will show 20, but actually you will be having 2 lesions there.
All right. So I think you have believed in this concept, but at least in my case, with the current technology, what we have been adopting, making a good anatomy by looking at the CP superimposition or registration, whatever you call, and all the time, obtaining the esophageal temperature monitoring and your contact force and the accuracy of the lesion, the effectiveness of the lesion by many of the algorithms with this contact force tacticat kind of a catheter. I was thinking with 20-30 watts, particular spot for 10 to 15 seconds. If you go on doing it, and if there is absence of any electrical activity inside the PV, and then if you reinduce and then you look at some adenosine response, etc., according to me, is still a safer bet than going with the high power short duration. And if you are adopting HPSD, I think that short duration has to be kept in mind, because if you exceed 20 or 20 plus seconds, whatever you think, the catheter is not stable, maybe the lesion is okay, lesion is not effective, and that is why you went with 40 to 45 and up to 20 seconds. I think in my opinion, shouldn't be done. I think
in the ridge area particularly, sometimes even with a single point, single location, you require higher because your signals don't go away. Like I showed you, in this case, the ridge was 1 centimeter thick. So on the top of the ridge, you have to give more than 15 seconds, even with 45 volts.
See,
Otherwise,
the definition of a ridge on just your penta-ray mapping and reconstruction of the anatomy, it is still, calls for a question. If you have superimposed with, say, some CT scan images, I think, that is okay. You should always be guarded because of the anatomy, what is that you have acquired, especially with penta-ray. The anatomy can be misleading.
yeah, so the penta-ray, there have been studies published correlating with the CT anatomy, and they have found it to be pretty accurate near the CT anatomy. Only thing with penta-ray is that there are ghost shell which is created, but that's not the case with the ridge area. So yeah, but you have make sure that you have to keep the FAM resolution at 20. If you keep the FAM resolution less, then you will be having not good images. But I agree, CT will be there. But most of the centers all across the world are not routinely doing CTs for doing AF ablation.
Yeah, true. But when the experience is just building up, for example, I think you have done the largest in the country with HPSD, and your number is not more than double digits. So I think everybody should be cautioned here when you are talking about AF ablation. On top of that, if you are talking about such high power and the duration more than say 15 seconds, I think the caution needs to be exercised. Your talk is great, but it should not be an inspiration to jump onto doing this before somebody has done the regular way of AF ablation for at least some 50, 75 cases. This is the message which I would like to convey.
Excellent point, Ullas. I think all enthusiasm for anything should be tempered with some caution, and a very good point there. So, Avinash, do you do your CTI ablation with? Yeah, I want. Yeah, please go ahead.
Yeah, Avinash, excellent presentation, very nice case. I just have one question, kind of a comment to make. As Dr. Shiv said that this HPSD has been there for years together. Yes. Why it has not become the choice care as of now for us to do ablation? I really need to understand that.
Ma'am, publications are coming, randomized trial, particularly with 45-60. Ma'am, actually, particularly the contact force and the technology, particularly things like ablation index and all that quantify all these variables. So it is an unforgiving ablation because sit down, if you have all that work which I do, it will be damaging. Ablation index is coming to make life easier. You just have to follow one value instead of looking at all these things. So all these things are coming, and as Dr. Shiv was also saying, more and more RCTs are coming on this. But if you talk about the data, then Dr. Natali's group, he has published of more than 13,000 high power short duration AF ablation data. There is a lot of data from Japan as well. So a lot of RCTs are come in this.
Okay.
So Avinash, do you do your CT? Have you done CTI ablation also with this thing, high power ablation?
Yes, sir.
Okay.
So in this group also of 10 patients, CTI was done for nearly, I think, 4 or 5 patients, and it was the same ablation. But over there, I don't go for the 5 second or 4 second. I see the impedance drop as well as the EGM's gone. So if the EGM is going and the impedance is dropping, I stop it. So particularly if I'm going down near the IVC, then I make the power go down, because otherwise it's, I'm not that sure I should go that high power near the IVC. So that is why I take the power down.
It can be a very thin walled structure sometimes.
Yes. So there I take down the thing. But otherwise on the isthmus, I go for 45 watts.
That was an excellent presentation. Any other comment from anybody?
I think we don't have any more comments, Dr. Saxena. You can wind it up, please.
Yeah, so I think we can close this session. Thank you, everybody, for joining in. It was a
I
great
just
session.
have
Thank you so much.
I just have an announcement to make, Dr. Saxena, with your permission. The next session on Friday will be at 5 p.m., not 6 p.m., but 5 p.m. I will be sending the link very soon. Thank you.
Thank you.
Vanita, why is that?
Don't change the timing so
Some time
frequently.
adjustment. No, we are not changing it frequently. This is the requirement for our US colleague. One of them, he's requested it specially. So we are having a talk from Dr. Shunmunga from Madurai, and Dr. Vijayaraman is going to chair that session, moderate that session. So he is on hospital duty that day. He just requested if we can do it, and I think we can do it. I mean, let's be more adjusting.
Okay. Thank you, Vanita.
Is that okay with everybody? Yeah. Thank you so much. Thank you for being a great audience.